stated that while we get frustrated that we're not maybe doing as much as we would like, that in fact this group is trying to do what it can, and what it can do is be a reasonable avenue for the community and for researchers and funders, and it's one of the few places all three of those come together, can have an honest discussion about things, express their frustrations. And as we've seen, we've made up recommendations that sometimes have been listened to and sometimes haven't. We're not satisfied with that. And we did talk about ways to get around that. And I think one of the suggestions that came out of that group and the discussion right before we went to break for lunch was that I think that we need to have either the Secretary herself of Health and Human Service or a designee that is standing in for her to come to address this group, to restate what their goals are for this group, and a commitment from them that when we do put forth recommendations, that it reaches that level with some, with some degree of confidence that we know that our recommendations are at least being read.
Jim, towards that, what you just said, several years ago, I think we had Dr. Aguinobi come to one of our meetings and made a pledge to come to at least one out of every other meeting. And that was unfortunately the last time that we saw him, but I think he had left the department. And so the question would be whether the current administration would sort of honor that commitment from Dr. Aguinobi. And I would certainly like to see the presence of somebody at a portion or all of, at least every other meeting, like in the past was committed to us.
Okay, I think the level of the commitment may be negotiated, but I think certainly some presence that we know that who we are working for is listening to their own committee. And it sounds like your subcommittee had the same sort of sense that the research.
Certainly open it up to the rest of the committee to weigh in on that.
Okay. All right. Is there any other committee ready to present? Okay.
Jim, just as a point of order, I think that I think on the agenda we're looking at it being discussion of recommendations rather than necessarily reporting. We reported on committee yesterday.
Yeah. Well, this is just to get that started, okay, because I'm hoping the committees would have some preliminary recommendations, and you're waiting for your slip desk, right?
I just delivered it to Marion, who's doing the thing.
Okay, so
Jim, I could just maybe real quickly, just to wrap up the research subcommittee.
Okay.
Just because I know that once they get that disc in, we'll turn things over to you. It's clear that at least Art. And Ron and myself have had many discussions about how we can basically, make a difference. There's a tremendous number of patients out there who are feeling like they don't have access to good health care, that treatments that work, availability of physicians. And I think what our committee is really about is how do we get research supported at different levels, both at the NIH and CDC, so that there's both an infrastructure of support available and empirically validated procedures. So that's really what we'd like to see. We'd like to see a sea change. Right now, it's very difficult for patients to get access to the types of services they need. There's not enough physicians. There's not enough training, so that everything our subcommittee does really kind of impinges on the other two subcommittees. So there's a tremendous amount of kind of, in a sense, disappointment in some way when we hear testimony every 6 months and we hear the desperate situation that patients are in, and we recognize that we want to do something. We want to be able to see something change. And and I think the hope of probably thousands of people is that some of these new research findings might make a difference. And I think that's kind of spurred a tremendous amount of excitement on our research subcommittee, and we hope to the committee as well.
Rebecca?
Along with what Lenny's saying, I think one of the issues that we keep coming to is access to care. Even if XMRV turns out to be it, that's the thing that you test for with CFS patients, there are not going to be people who can treat this. You're still going to be looking at the same group of doctors who are specialists to treat this, and so all of these people who are suffering are still going to be suffering and waiting for doctors. And I think that as a patient portion, and Lenny, I just want to echo what you're saying, is that need for physicians is huge. Nancy's what, 3-year waiting list still? Okay, 3-year waiting list. So even if we cloned her three times, we'd have a year waiting list. And that's, in Florida, where I live, which is a very large state, if you're going to see a CFS doctor and you have Medicare or depend on insurance, Nancy's who you see. That's the entire state. That's who you're going to. Because most of our insurance is state. Even if you have a private policy, you have to go within your state. So there's a tremendous burden on the patient population who are suffering. And as you hear them, and I put Kleenex there because I saw everyone tearing up yesterday. So I borrowed Kleenex from my hotel room and brought it, and I'll take it back tonight. But I'm a good citizen, yes. But I think as we discuss this over and over again, and I guess this would be, it's not my parting thing, but really to leave with the committee is we have to figure a way to get clinicians to treat this illness. Because Nancy's going to retire someday. Her family wants her to retire right now. I've heard from their voices. She's not doing it. But, they're ready for her. And I'm watching everyone, and the hair becomes a little bit grayer every year. We have to get new researchers in. We have to get new clinicians in. And so we look to the ex officios. We really need your help because we don't know how to do this. My family practitioner, who I really tried to drag into this, finally was like, I'm happy where I am, but I tried really hard to get someone interested in this field. So any help and input you can give us as we discuss this, that's a big issue.
So I turn things over to the chair. Our research subcommittee report is finished, and I just want to echo what you just said. There's a crisis in this country. Business as usual cannot continue. We've got to make change.
Thank you. Chris.
I was just going to add to what Rebecca said, and I think it speaks to people outside of this room knowing what goes on in here. We have all of this passionate testimony that all that's happening is that people are already convinced they're hearing it, or are the CFS patients, and that really needs, people outside this room need to see that. It's there, it's very powerful. If you're not convinced that this is a real illness after you've seen these people sit there and tell us what their lives are like, why would you choose an illness like that?
Well, one of the things that I was going to do at the end was just thank Wanda for all the things that she did differently. And one of them, of course, is that this web broadcast. As I understand it, that web broadcast is going to be available. It's not live. They did.
It's live now, but obviously when we leave here, it won't be live anymore, and it then has to be archived, and it's put on a different server.
Yeah.
For that
I don't know if it'd be better or not to. And Mike might have some ideas on that. Is that maybe someone should talk to the news media? This is being covered by a website, and they probably would love to report on this if they thought it was a good story. And as you said, this really is a heartbreaker at times. And so if the people who were participant don't mind being, outed, if you will, maybe we should somehow ask the news networks, we had this meeting, this occurred, there's a tape of it, there's some very poignant parts of that tape, maybe you should look at it, and maybe someone would do a story on it. I think it's very compelling that you have